over to you.
Okay, so thanks, Stu. So basically, what we're going to be talking about tonight is specifically around ultrasound-guided injections, but in the context of a private physiotherapy practice. We just start by talking a little bit about what this talk is versus what it isn't. So this webinar won't be really teaching anything about sort of the technical aspects of ultrasound-guided injections. So if that's what you were looking for, then you can leave gracefully now. We won't really be talking, apart from possibly anecdotally mentioning anything really particularly around sort of clinical or treatment techniques. But what this webinar will be about really is discussing topics relating to setting up and running a service, with particular focus on some of the logistical matters, real life experiences, and sort of clinical governance aspects. Just a little bit about me. So I am chairman of ACPOMIT, which is the clinical network for people interested in injection therapy particularly. I am owner and I run Complete Physio, which we have a significant sort of branch of our services, which is Complete Injections, where we have a number of thousands of ultrasound-guided injections come through our services each year, predominantly in our 5 main London-based clinics, but we have a growing number of satellite clinics around the country, as far afield as Taunton, Bury St Edmunds, Brighton, Chelmsford, dotted around, which run predominantly ultrasound-guided injection clinics. I've been injecting for just under 20 years. I've been a physio for around 24 years, independent prescriber, and sit on a number of committees relating to all topics relating to prescribing, injecting ultrasound. And for my sins, I also do a lot of teaching with Stuart Wildman and Rob Mast, again, on everything to do with ultrasound and ultrasound-guided injection. So this is kind of where I sit within this particular sort of topic area. So what we're going to be talking about today is focusing on a couple of aspects of this, of a very loaded sentence, ultrasound-guided injections in private physio practice. So we're going to be focusing on a couple of particular aspects of that, which I'm not sure that are so often talked about and so freely available, if you like, the information around this. And it's really based a lot of it on real life experiences of setting up and running a service for a number of years now across multiple different sites with a number of clinicians. And so we're going to be talking about topics relating to training, clinical support and CPD. We're going to be mentioning from a number of different angles issues around clinical governance, touching on topics around documentation and image storage, medicines management, thinking about the actual clinical environment that these injections are performed in, specifically around topics of scope of practice. We're also going to touch upon some of the financial considerations, referral pathways and marketing, and also shared decision-making and consent. So a lot to get through, and hence why we're not talking about much on how to do the actual procedures themselves. But anyway, so just a quick reminder. So what are we talking about when we talk about an ultrasound-guided injection? So we're talking about a very targeted delivery of an injection, normally a prescription-only medication, to an area which you have formed a clinical diagnosis using your normal traditional physiotherapy assessment skills and clinical reasoning. And we're delivering a very targeted dose of steroid predominantly, but we do use other forms of injections such as hyaluronic acid, and we use a number of other sort of types of techniques, specific techniques such as barbotage, high volume procedures. Here's an example of something we might see on ultrasound, an area of calcification, and rather like a sort of fisherman standing there with his catch, because a physio standing there with their barbataged calcification. So it allows you to do lots and lots of different treatment techniques that you really wouldn't be able to do without the use of ultrasound. So, but it throws up a number of different topics, a number of different considerations, concerns, and logistical difficulties, which we are going to be talking through, quite aside from the actual performance of an ultrasound guided injection itself. So we just get through the pretty pictures of the ultrasound guided injections, okay, and then we're going to tackle some of the common, we'll say, misheld beliefs, but certainly something where I get contacted, I would say, certainly on a weekly basis, it feels sometimes not far off a daily basis, by people around the country, physiotherapists predominantly around the country, looking at, considering, contemplating, setting up ultrasound guided injection procedures within their services. And something that is often said of whether it be physios thinking about embarking upon use of ultrasound, or injecting physios thinking of embarking on using ultrasound to guide their injections, oftentimes the thing that people say is, well, it can only enhance my practice, it can only make me better at what I'm doing, so surely there's no risk to the patient, it's just, you know, me going out of my way to make the patient safer. And in one sense, I guess there is a lot of truth in that. But what we need to think about, and what we're going to be talking about today, is the way in which it really sort of changes the game a little bit in terms of how you're perceived, around patient expectations, around a whole number of different issues and aspects around what you're actually doing, and the, I say, medico-legal side of things, but certainly it changes the onus and the weight of expectation, and the relationship between yourself and the patient, and oftentimes also with the referrer as well. And that's something that we're going to be talking about from, again, a number of different perspectives and angles as we go through. So some of the limiting factors, particularly as a physiotherapy clinic setting up or introducing this into your practice, we need to think about some of the time factors. This is very, very time consuming. It takes up a huge amount of my sort of clinical time or my time as a practice owner, and we'll look at some of the ways in which this eats into your time again as we go through. There are a number of financial considerations, both around the training and some of the sort of hidden costs, if you like, within the training as well, which are important to mention, but also the outlay for the machine, the ongoing running costs of the machine, and lots of the other costs involved with performing ultrasound guided injections. So it's certainly not necessarily a cheap thing to set. So there are certain barriers to entry to the market with this particular type of treatment, which probably as physiotherapists we don't necessarily face with many other types of service that we might set up. And there's also obviously the sort of, as we say, the ongoing sort of maintenance and running of the service, and also the skill, the upskilling, the CPD, the need for clinical support, and all of these other aspects that we need to consider. So if we pick it apart, if we dissect this down even more, if we just think about the ultrasound component of this, because this is quite a chunk to consider just on its own. So ultrasound as a modality, okay, some of the key issues that we need to think about is that it's not very, it lacks regulation. So anyone can call themselves a sonographer, and as a modality, it is traditionally, or it has been, very poorly regulated. However, as a physiotherapist, with your parent profession, as a physiotherapist, then obviously we need to abide by the introduction of ultrasound as it fits into our practice as a physiotherapist. And obviously the same would be said for any other professional, healthcare professional that might be looking to introduce. So it's understanding the dynamics and the context of introducing something which is essentially unregulated into your professional scope, if you like, which is a regulated profession. So there's a significant dynamic within that in itself. We talk also about ultrasound as being very operator dependent. And by this, what we mean is that whereas MRI scans and X-rays might be very standardized and very universally sort of transferable images, ultrasound really very much depends on the person who's performing the ultrasound and the level of training, the level of skill that they have, how vigorously they interrogate the structures that they're looking at. And so there's a whole manner of things, the ultrasound machine that they're using even. So there's a whole manner of things that can affect the outcome and therefore, for all intents and purposes, the quoted diagnosis from that particular ultrasound scan. There is a distinct lack, particularly as we stand at the moment in 2023, although I would say that things are improving. Certainly I've been scanning for, 15, 16 years now, I think, and certainly things have significantly improved. But the demand for mentoring and the demand for access to high quality supervision and education continues to outstrip the availability of mentors. And therefore, this is always an issue for people that are looking to go through this training. It's a rapidly developing and evolving area of practice. And so therefore, it inherently requires it's inherently a changing landscape, both in terms of the actual sort of profession or the professional context within which it's used, if you like, clinical context within which it's used, but also things are changing and evolving all the time. And that, involves machines, the cost of machines, the types of machines that are available, for example, the handheld machines that are coming onto the market at the moment. Techniques and skill levels are rapidly developing, as are access to a whole plethora of different types of CPD and educational materials that are becoming available. And so just the ultrasound component of this, as you can see, is quite a difficult thing to manage in terms of introducing it safely and with the appropriate governance into your clinic. I would say probably essential reading here is the Chartered Society of Physiotherapy's papers, information papers that they released a year or two ago, which really helps to guide us as physiotherapists in terms of, what we need to know, what we need to be doing and what we need to be aware of in order to sort of safely bring this into safely bring ultrasound into our clinical practice and to make sure that we are, safely integrating this and being aware of all of the issues around the use of ultrasound within our profession. Shameless plug, but you'll see that both my name and Stuart Wildman's name is on this paper, which was published just a few months ago. This is looking at a proposed framework for POCUS, point of care ultrasound and ultrasound guided injection interventions by physiotherapists with a keen focus on scope of practice, education and governance. And obviously I'm alluding to many of these sort of key points from this paper in the talk tonight, but I would still strongly recommend having a good read and a digestion of this paper, because it's really, another sort of very much a sort of flag in the sand, if you like, around sort of how we should be guiding our profession and how we should be guiding clinicians going forward with these new tools. And in particular, we have this framework triangle, which is looking particularly at the scope of practice of the clinicians. This is ultrasound, but I would put the same weighting here on ultrasound-guided injections as well, and clinical governance and the education and competency of clinicians. So what about training, support, and CPD? What are the issues here? What's going on with this? So, what do we need to, training and qualifications wise in order to bring ultrasound guided injections into our private practice? Well, we would hope that the top box is ticked, musculoskeletal assessment. Also, on top of this, we would strongly recommend that you have obtained a qualification in injection therapy, which is consistent and congruent with the CSP practice and development documentation and recommendations on injection therapy training. We would strongly recommend that any physiotherapists would obtain an ultrasound imaging qualification, PG cert from a higher education institute, M level, and ideally this should be CASE accredited. So the Chartered Society of Physiotherapy is a member organisation of CASE, which is the consortium for the accreditation of sonographic education, and therefore the CSP's recommendation and will endorse that we should the physiotherapists should ideally be attending courses that are CASE accredited when obtaining their education in ultrasound imaging qualification. And the reason for this is because they regulate the courses, they regulate the standards of education, and there are a number of components within or CASE will look very thoroughly at courses before awarding accreditation or awarding their endorsement to ensure that it contains all of the core and key components that are required in order to safely perform ultrasound imaging. And so therefore the CSP very much recommends that courses that are attended are CASE accredited. We would also, I would suggest, strongly recommend that if you're doing ultrasound guided injections in private practice, that you get an independent prescribing education. And there are a number of qualifications, and a number of reasons for this. So in order to screen your patients safely from a medical perspective, I would strongly recommend that you need the depth and breadth of the training of an independent prescriber in order to make those clinical decisions, but also to have that broader awareness of drug interactions, adverse drug reactions and their management, and just understanding the broader context around supply and administration of prescription-only medications. So on a number of levels, I would strongly recommend that any physiotherapists that are contemplating doing this would acquire an independent prescribing qualification first. I would say that also logistically, it is nigh impossible to run a service of ultrasound guided injections really without having this qualification, because otherwise you are having to send a patient to their GP, and remember that they would require a private prescription from the GP. They couldn't get an NHS prescription from their GP for you to then inject it privately. So the logistics of obtaining the medication and obtaining the prescription from the GP, if you are not if you're working in private practice in the context, is actually quite complex and quite difficult, and it means that very oftentimes the patients will just get lost in the journey. And that's certainly, as was my experience when we tried to do this many, many years ago without having the independent prescribing qualification at that time. There is also a significant need for mandatory training. So this is training that would, for things like management of anaphylaxis, management of adverse reactions, sharps, a whole plethora of mandatory training that we have to put all of our clinicians through every year. We also get all of our support staff to also undertake emergency first aid training. We do a lot of training around advanced sort of infection prevention and control, management of hazardous waste, etc., that, again, you wouldn't necessarily need to do in your sort of normal physio practice. So again, there's a lot of sort of collateral further training that is required in order to do this. The next sort of tier to this, as well, as we mentioned already, is around the actual training of the clinician to perform the ultrasound guided injection. And one of the biggest barriers here is the supervision and mentoring. So there's just simply a lack of people available that are ready, willing and able to give this supervision, particularly in private practice. So it's pretty difficult to come by, even working in NHS, but in private practice, by the very nature of it, then, you know, finding someone who's willing to come into your practice or is able to allow you to go and receive mentoring and supervision within their practice is logistically very, very difficult, not least because oftentimes in private practice, the people in your region that are doing this will, you know, potentially see you as a competitor coming into the market. So there isn't much incentive for them to train you up. So it's quite difficult sometimes to get these to get this service off the ground, if you like, unless you've got someone coming in who's already, you know, quite skilled and experienced in this area. There is a significant amount of cost. So to go undertake all of that training that we just mentioned, and in particular to undertake the ultrasound guided injection training and mentoring, can be quite a significant outlay. Oftentimes people are having to buy in mentoring, and that can be a significant additional cost. You also need to think about the patients that you're going to be training upon. So the patients, so where are the patients being thrown from? What's the lines of accountability and responsibility for patients that are being injected as part of your training? And it'd be really important that you check with your insurance, both the person who's being mentored and also the mentor really need to be very, very clear about their insurance and how this would work if you're treating patients within a private practice setting, where the lines of accountability and responsibility start and finish. And that's even if you can find patients that are in private practice, that is, that are willing to be, if you like, you know, injected as part of your training. So oftentimes people accessing these services in private practice are wanting someone who's already got a lot of experience. So, you know, it can be difficult to get those first 100 injections or whatever in private practice versus if you were working within a NHS department, for example. So there's lots and lots of considerations on this that, again, sometimes, you know, people are less aware of or give less sort of thought to, like, where are we getting the patients from? Whose patients are they? Where's the insurance cover? And also even from a medicines management perspective. So what are the lines of prescribing, supply and administration? If someone is supervising you to perform the injection, who's making the prescribing decision? So all of these things, you know, the devil is in the detail with this training. Access to clinical support ongoing. So you'll be aware that, ultrasound, we often compare it to, learning a musical instrument, in that, you sort of year on year, you never stop progressing. And, I've been scanning for, I say, many years now, but even so, on a regular basis, you will come across things in clinic which, you haven't seen before, or appear unusual, atypical. Where's your clinical support? Who's going to support you in those decisions? So it's really important that you have links with people that are able to give you that clinical support. I would suggest that, if you're performing an ultrasound guided injection, something that I feel, very sort of, strongly about, is that, before any injection, you really need to make sure that you do a full scan. And I can talk of a very recent scenario where a patient was sent to me for an ultrasound guided injection, and the report that they came with, so they'd already had an ultrasound, was entirely wrong, absolutely, completely wrong. And when we scanned them, it was very, very different to the report that they'd attended with. Now, had I performed that injection without performing a scan first, then potentially that could have been a very, very difficult situation, because the record that this patient had was that prior to my injection, there was no problem with their rotator cuff and no problem with the bones around their shoulder. The truth actually was that there was some very significant problems when we scanned them. But had I performed the injection first, the risk is that the injection may have been, potentially blamed or held responsible for the significant changes that would, very likely have been found further down the line. So, and that's just one of numerous examples that myself and colleagues that I know that do these will always say, absolutely 100% you perform a scan, as you do an assessment, and you scan them before you do the injection. So satisfy yourself. There's no reason why they shouldn't be having an injection, but also to make sure it's clinically appropriate and indicated. What are you going to do to manage unexpected findings? So they will come up from time to time. How are you going to manage these? In clinical practice, private practice, it can be quite difficult. You might have a patient who's just driven 100 miles to come to see you for an ultrasound guided injection. Believe me, that happens on a daily basis within our clinics. They turn up and you say, hold on a minute, I'm just not too sure about this. It's a bit atypical. The ultrasound image doesn't look quite, I really need you to go for a check MR scan. There can be a lot of pressure. There can be a lot of expectation around the fact that they've just driven all this way. They won't necessarily understand the differences between the different modalities and what one sees and what the other can see. And so you can find yourself really in some quite difficult situations unless you prepare and manage these people's expectations, unless you have that experience and confidence to deal with and handle these situations. And you need to make sure that you have all of your pathways in place to manage any urgent or any patients that require urgent review or urgent medical review. So some of the sort of governance topics that we're going to mention. So, quality assurance. So the machines need to be checked regularly. They need to have calibration checks. You need to make sure that you have, infection prevention and control policies and procedures, which include the management of the ultrasound machine and everything to do with your injections as well. Certainly you will need to review most of, if not all of your policies. Health and safety policy will all need to be rewritten and significantly expanded to take into account these new services that you might be offering. There will also be the need for a significant number of additional policies around ultrasound guided injections, around the use of ultrasound and various other aspects of, sharps disposal, hazardous waste, you name it. There's a whole plethora of guidelines and policies that will need to be written. Also standards and competencies. So we have internal competencies and scope of practice sort of declarations and documents for all of our clinicians who perform ultrasound and perform ultrasound guided injections. It's really, really important that they have access to training and also regular and ongoing CPD. It's essential that anyone performing ultrasound and ultrasound guided injections clearly defines their practice and can underpin their scope of practice with direct evidence of training. So if you go on an diagnostic ultrasound course, it's very common that even if you try to do quite broad area of training, that by definition of the context within which you work, you are going to get a greater or lesser exposure to certain types of patients and certain types of pathology. So whether if you're working in a sporting environment or if you're working more in a sort of like primary care NHS environment, you might see less muscle tears, for example. You might see in certain contexts, you might see less rheumatological presentations. So it's really important that you are, self-effacing around your scope of practice. Be very open and honest about, the training that you've had within each area. So when you're sort of signing yourself off as an MSK ultrasonographer, it's really important that you can define actually which areas that you are competent in and which areas that you might need some further or additional training or some refresher training at some point would be my very, very strong recommendation. Managing risk. So anything to do with injections, we need to be thinking about, in particular, how we're going to manage adverse reactions, drug-drug interactions, and therefore we need to think about, how we're going to manage a patient that might become acutely unwell within the clinic, how we're going to give information and make ourselves accessible to patients that might be experiencing anything from post-injection flare, or if they're worried or concerned in the days after the injection. So in terms of your writing risk assessments, again, you will be writing a lot of risk assessments around all of these different areas of the potential complications that you might face when performing ultrasound guided injections. But also strongly recommend producing a comprehensive patient information leaflets which cover the whole breadth and depth of what you're doing. So patient information leaflets about ultrasound, what it is, what it isn't, limitations, etc., as well as patient information leaflets about the different types of injections that you perform. We need to, as you say, have a strategy in place. Things will happen. Adverse reactions are going to happen from time to time. If you're seeing large numbers of patients, it's how we manage them, but also how we have foreseen that this might happen and how we've prepared to manage them in order to keep our patients safe at all times. And also think about auditing your practice, auditing of your ultrasound, auditing of your ultrasound guided injections. So we run a sort of rolling audit of notes for all of our services, but we have a particular concentrate around ultrasound and ultrasound guided injections. Also think about data collection, outcome measures. How do you assess your clinical effectiveness in these patients? So what strategies do you have in place? What structures do you have in place in order to get this information to, again, be constantly evaluating your service and improving your services? So from a clinical governance perspective, we're just going to, put a couple of papers up on here. Again, these would be sort of very much sort of recommended reading, if you like, around. So this is from the European Society of Radiology. Here's the Royal College of Radiologists, Standards of Provision of Ultrasound Service. We've got BEMUS statement on point of care ultrasound, and more recently BEMUS has released guidelines on the administration of ultrasound-guided injections, and brings us back as well to this whole topic around quality assurance. So actually finding someone that can come and perform maintenance checks on your ultrasound machine can be quite tricky, because most companies and organizations that perform these aren't particularly interested in coming and checking one or two machines. They want to come and check radiology departments, or they want to check like industrial size ultrasound, setups. They're not interested in coming and looking at one machine. So first of all, actually finding someone that can perform this can be difficult in physio private practice. It needs to include, as well as all the maintenance checks, calibration checks. So making sure that, for example, all the different settings on your machine are appropriately calibrated, the visibility of the ultrasound, so the needle visualization is all set up and working correctly. We need to obviously keep an audit of these checks. So there's a whole number of different additional things that we need to be aware of, that we need to build in and bake in to the setting up of these services. So when we're thinking about machine, we get asked on a very, very regular basis about, what machine would we recommend and this kind of thing. Well, obviously, it's quite a significant financial outlay for a private physio practice. I would suggest that to buy a machine that will adequately be able to perform diagnostic quality ultrasounds and which is necessary to be performing ultrasound guided injections, you need to be thinking around about a budget of at least probably £20,000 or more. And then all of the additional costs around sort of insurance, quality assurance and maintenance checks and all this kind of thing. So it is a significant outlay, but when we're performing ultrasound in this sort of point of care setting, unless people have like vast sums of money, this is inevitably going to limit to a degree the quality of the ultrasound. So a £20,000 machine will be perfectly adequate for scanning the majority of musculoskeletal. But you need to be aware of the limitations of your machine. You need to be aware of when you might need to refer on to a machine with a higher level of spec, or refer on for other forms of imaging. And you need to be aware of the impact that this will have on the image quality, but therefore the diagnosis and the clinical decision-making with using that machine. I'm not going to go into too much detail around the sort of documentation and records, but to say that obviously if we're doing ultrasound guided injection, it needs to be, and it's really important to be aware of the fact that you are doing this as a physiotherapist. So it's really important to remember that you must, even if someone's just referred to you for an injection, that you have a professional responsibility and a duty of care to perform an assessment of that patient. And you are essentially making an autonomous decision around whether or not to make to perform an injection, and obviously that needs to be reflected within your notes. Also, a heavy onus on the explanations that were given. We have a very significant sort of pre-consultation screening form that we use. With lots of, again, patient information materials and leaflets that are given to the patient before they even turn up, so that we are sure that the patients are arriving already aware of a significant amount of potential information before we even get started. Gaining consent is essential, and the CSP recommendations is that we should always gain written consent for an injection, because they can have, potentially very significant could potentially cause a very significant injury or even a sort of life-altering adverse side effects or reaction. So it's really, really important that we have clear documentation that the patients have been made aware of this before we're proceeding with any sort of invasive procedure or injection. So along with the typical notes that we would have, we need diagnosis and rationale for the injection, and include the fact that we've talked about all the different treatment options, that we screen them for contraindications, and evidence that there has been some element of shared decision making with the patient, including advising them about all the potential risks and side effects. Medications used, so again, people that inject will be familiar with this: batch numbers, expiry dates, your no-touch technique, any post-injection adverse reactions, protocols, incident reporting, and specific post-injection management advice. We actually have now a post-injection leaflet, which is subtly or slightly different from the pre-injection leaflet, which is just a reminder and very much focuses on that post-injection monitoring and management. And we upload copies of all of the materials that the patient has had been given access to their notes for each episode. So within the patient records, you've got your documentation, your consent form, and all of your patient information materials. Also, is really important and something to mention, and that is around the image storage. There's a big move away from performance of what is known as ghost scans. So by a ghost scan, we're talking about a patient coming along, having an ultrasound scan, no record of the scan, no images or anything of that nature. So there's a big move away from that for obvious reasons. Could potentially be very, very problematic if a pathology is missed, or if the patient misunderstands what they've been told, or any of these things. So there is a really big emphasis now on the need for image storage for every patient that you scan, and that they have all of the information around, time, date, location, name, all of these sort of like standardized, but also a report that goes with these ultrasound images. Increasingly now we get asked by patients to send them copies of their report. Increasingly now we get asked by patients after injections to send copies of the images. And I would, where possible, include an image with the needle placement as well, because it just confirms that the injection was delivered to the target structure. So from a medicines management perspective, we've talked about, prescribing. I would say that logistically, it's extremely difficult to work in private practice other than as an independent prescriber. But I would also say that from a patient safety perspective, in my honest opinion, I think that undertaking the training and having that broader understanding is really essential if you are going to be doing, taking this up in a meaningful way. Obviously, you can perform under patient-specific direction, particularly if you, share a clinic space with a GP or someone who's able to, prescribe on your behalf. But I would certainly be looking for, and I would always endorse and encourage people to undergo the training wherever possible. Issues around, so we typically do the prescription for the patient. You can send the prescription to the patient for them to pick up. I would say logistically it's much easier and works much more smoothly, in my experience, is if you find a local reliable local pharmacist, and you can just take all your prescriptions along there and collect them for your patient on behalf of the patient. Remember that as physiotherapists, we're not allowed to just bulk buy medications. So each medication that we have essentially has to be prescribed for a named patient. And also think about, your sharps and clinical waste disposal. And again, it all comes back to your sort of clinical audit and your sort of clinical governance. So the environment, as we know, physios do not have to be CQC. However, we would strongly recommend that the environment that you perform this in would be reflective of, either, the equivalent of a sort of minor ops room, or certainly a very clean and regularly cleaned environment with a specific and dedicated area where you do the preparation of your injections. Make sure that you are au fait with all of the issues around sort of no touch technique and maintaining sort of a sterile environment when performing the injections. Make sure that you have everything in place to manage an emergency. So we have as standard like on-site defibs. We have, as we mentioned earlier, like people are trained in emergency first aid. And we get as many staff as we can through that each year. We have a minimum of 2 emergency first aid trained staff on site at any time when we're performing injections, and we have a flat out ban on performing injections when lone working. And I would say that you do not want to be managing a patient who's become acutely unwell or even fainted or vomiting or any of these things, trying to sort of look after them and care for them, and simultaneously trying to alert emergency services. So we have a local policy, no lone working when we're performing injections. And again, I would strongly recommend that would be a good standard of practice to uphold. Be very aware about your insurance. So obviously I can't talk, and it would be inappropriate to talk about people's specific insurance, but if you are talking about introducing this into your practice, make sure that you speak with your insurer. They are fully aware, and that any changes or adaptations to your insurance that need to be made are made, and everything is sort of clearly understood. You'll be aware that there are little tick boxes even on the standard sort of James Hallam insurance at the moment to say that you only inject within your competency, you've undergone the appropriate training, etc. So it's really, really important that everybody is aware of what you're doing. And so if you're changing your services, I would certainly recommend that you talk about this and discuss it and agree it directly with your insurer. Be aware as well that injections that you might perform in the NHS, for example, nerve block, suprascapular nerve block, lots of physios now increasingly are doing spinal injections in NHS. They are not covered within your CSP insurance, and therefore, so your insurance, if you like, is under your hospital's vicarious liability, but you cannot do these in private physio practice unless you have specifically sought and obtained insurance cover in order to, and you need to be absolutely certain that they are clear about what they are insuring you to do. And it certainly doesn't come under any standard insurance at the moment. So just be aware of that. And spinal injections are, they really, the recommendation in the national guidelines are all about spinal injections being performed in theatres, that you should have, access to emergency medical support, recovery room, and all these things. So they are really not appropriate to be performed in a sort of normal physiotherapy practice. So again, this is very much sort of a practice that has now been sort of, moved away from. Be aware of your own knowledge, skills, and competencies. And again, be really careful about defining your scope of practice. Consider the depth and the breadth of the training that you've actually undertaken, and ensure that you and the exposure to the range of pathology and conditions that you've actually had, and also awareness of other modalities, MRCT, that may be more appropriate for assessing and screening the condition before you perform an injection. So either as a diagnostics, but also, for example, frozen shoulder, we know oftentimes we're encouraged to refer for an X-ray for certain, knee or hip presentations. We might want to get an MR just to rule out, make sure there's not a stress fracture or avascular necrosis or anything else, some sort of insufficiency fracture, or even in osteochondral defects, which we might, not want to expose to the steroids. So it's really, really important that we're aware of the limitations of ultrasound and what modalities actually show us which conditions, particularly the ones that we might not want to be injecting with steroid. So being really, really clear about our scope of practice and aware of any further restrictions to practice due to the limitations of the equipment that we might be using, and also maintaining our competencies. So going back to the finances, you need to consider the initial outlay, your ongoing costs, and also the significant clinical disposables, PPE, cleaning products, and all of these other sort of costs. Some of the sort of, I would say, hidden costs, but more stealth costs, such as, changes in insurance to yourself, to the machine, quality assurance. All of these things need to be taken into consideration. So I know oftentimes people look at the sort of headline figure of what you can charge to perform injections and ultrasound guided injections, but we need to be aware of the fact that this is counterbalanced by significant amounts of outlay, additional outlay for what we would normally be exposed to. So be really, really aware of the patient pathways and screening. We get lots of referrals from consultants, but we get referrals from osteopaths, physios, patients coming back to us that we've treated for other conditions. And so managing expectations and screening the referrals, making sure that they're appropriate, is a real challenge. And we have put a huge amount of resources into front-ending our service to help screen and wean before patients arrive. As I mentioned before, your worst nightmare is the person that has just driven 100 miles and then immediately they are inappropriate for an injection because their shoulder pain is actually a neck pain, or their knee pain is blatantly referring from their lower back, and these kind of things, which again you will get from time to time. You won't eradicate those completely, but you want to absolutely sort of minimize those by your screening. As yet, very, very minimal opportunity for insurance companies to fund these. Certainly the big insurance companies don't usually fund physiotherapists to perform injections. Occasionally you might get the odd patient with a sort of more bespoke insurance policy that may cover them for a one-off injection, but I would say 99% of the market is sort of self-funding. Be aware also about onward referral and access to other diagnostics. So again, someone presents to you, they've come to you for an ultrasound or an ultrasound guided injection, and then you're saying, well, actually we can't do this, but what you need to do is go off and have an MR. And they're like, well, I'm coming to see you because you can scan, so why are you now saying that I need an MRI scan? So again, you've got to be really, really clear with the patients about why these additional sort of like onward referrals sometimes are required. And particularly with your self-funding patients, it can cause, a degree of sort of anxiety. And so you need to, obviously make sure that you're managing expectations around that. So we have referral screening, we use telephone screening, we use, I'd say, a whole plethora of materials that we supply to our patients before they attend for the appointment, patient information leaflets, lots of materials around treatment options, lots of materials around risk and side effects. We obtain signed consent as absolute necessary, and we get them to sign consent for each injection to ensure that they haven't forgotten, or that any of the materials that we supply to them haven't changed since they last came in for a procedure. Gives them an opportunity to ask questions, but it also highlights the significant difference, I would say, around potential risks and side effects of performing an injection compared with other sort of physio modalities, and advising patients around, you know, potential risks and benefits can itself be, you know, can be a challenge, if you like, but it's really, really important that you make sure that they are fully aware of all the different potential risks and side effects. You'll be aware of the Montgomery standard, which really means that we have to advise patients about all potential risks and side effects, whether we think they are materially relevant or not. I'm not going to go into this in too much detail tonight because, again, it's a sort of a side issue, but I would strongly recommend worth reading some of Pip White, who has written some excellent materials and articles around the Montgomery standard and how this relates to our sort of practice as physiotherapists. There's challenges around applying evidence-based practice when performing injections. We'll get oftentimes patients rocking up wanting injections for tennis elbow, just to name a sort of an obvious one, or the patient who wants you to inject their plantar fascia because they're about to go off and climb to Everest Base Camp. And what I would suggest, you know, what I look to is that some of the materials by Neil Maskery, who's a bit of a hero of mine when it comes to informed decision making and consent, has done some amazing articles, really, really interesting read, fantastic, you know, clinicians sort of mindset around sort of shared decision making and informed consent. Really, really interesting topic. He talks about this, you know, you're the expert to advise on disease etiology, prognosis, treatment options, but they are the expert of their condition and the context, the impact that it's having on their life, their values and their attitude to risk. So is it a risk that they are prepared to take? Because to them, you know, they see it as a risk that they are prepared to take in the context of what it means to them, i.e. they're about to go and do Everest Base Camp. They're prepared to sort of like, you know, take on the risk that they could have an adverse reaction to the tendon or whatever. So again, beyond the scope but just to be aware of, these are the sorts of conversations that we may find ourselves having with patients that are accessing these treatments. So can ultrasound and ultrasound guided injections, you know, does it influence our decision? Well, some research says that performing an ultrasound means they're more likely to have an invasive procedure. So there's the risk that you could coerce people into having an injection, for example, or more invasive treatment. But equally, some studies suggest that actually, you know, if the information is delivered in a particular way, it could actually reduce the chances of somebody looking for invasive treatment. So I'd say that one sort of sits on the fence a little bit. So it will change the patient's decision, and the impact on the patient's pathway probably is a result of and relates to the way in which the information is delivered. And that's, again, we can go back to what we were talking about earlier in terms of, you know, consenting people correctly and helping people to make informed and balanced decisions. So we're getting very close to the end now, are there any potential, I always have to put this in because it's something, again, that, you know, I would say you have to be very aware of. Are there any potentially negative consequences to performing ultrasound leading to potentially an ultrasound guided injection? Well, yes, there are, because we said it's very operator dependent. So if you get the diagnosis wrong, then you could lead to incorrect management. It could be a misinterpretation of the image. So you could look at something and think and interpret the image erroneously, which then leads to suboptimal management. There could be a failure to recognize a normal variation, which leads to an over-treatment or an over-investigation of a condition. We could increase the patient's anxiety and lead them to end up having either surgery or other forms of invasive treatments. And I guess probably the worst thing is that the patient thinks that they've been screened for potentially serious and sinister pathology because they've had an ultrasound or a scan Whereas, you know, we're not actually scanning them for lumps and bumps. So that's something that we make very, very clear in our literature when we give it to patients, the limitations of the scan that they've had with us. In other words, we are not looking specifically for lumps and bumps. And so they haven't had that excluded, because this could obviously lead to delays in diagnosis of sinister pathology. So finally, if I haven't done enough to put you off setting up ultrasound guided injections in private practice yet. So finally, you know, these are to me, these are the real life considerations. So I get asked all the time, lots and lots of questions about setting this up, and, you know, and lots of, you know, very, you know, they good questions and appropriate questions, but they're usually fairly easy to answer, and there are solutions. Whereas I would say that the real life of this is that actually it's the how you sort of like, it's how you glue it all together, which is a lot of legwork, a lot of running around, a lot of phone calls, a lot of emails, and a lot of screening, to make sure that the people that come to your clinic are appropriate, they're dealt with appropriately and safely, and that they have access to you to manage, and so they've got access to you to talk about any concerns or anxieties that they might have after the injection. So you need to be available for that as well. And so it is no small undertaking. That said, as I say, I think it is a fantastic adjunct to the role and our profession as physiotherapists, and it's something that I feel very passionately about, and I believe that we make a huge impact and we can make a huge difference to patients' lives by integrating this with what we do. But it's really, really important that people understand a lot of the broader questions and the broader landscape around bringing this in to their practice. And some of the most important issues are actually around things like the screening and the consent, and the making sure that patients have a very realistic idea of what the injection will and won't do. I always say, sort of, you know, sell low, deliver high. Yeah, it's like basically, you know, under egg, if anything, manage their expectations plus around the likely outcomes, and then, you know, everyone's, you know, most likely to be happy with the treatment. But if you go sort of market in as, oh yeah, this is the silver bullet, this is the, you know, this will cure all your sort of aches and pains or whatever, then expect to spend quite a lot of your time dealing with patients where they feel it hasn't quite lived up to their expectations. So anyway, talking about living up to people's expectations, I'm going to hand back over to Stuart in a second, but I just want to do a couple of very shameless plugs. So there's a picture of us doing some of our teaching at Brunel. So you'll be aware that we run some PG cert in musculoskeletal ultrasound, which is case accredited. We've got a PG cert specifically in foot and ankle ultrasound starting in September, with case accreditation pending. We also run a number of other courses, short courses, non-accredited courses, and lots of courses around injections. They can be cadaveric, non-accredited courses, cadaveric courses in the anatomy labs, all the way through to accredited ultrasound-guided injection courses run at Brunel. All of this information and more can be found on the ultrasound site, and lots of nice graphics around sort of journeys through sort of training and education. So I'm going to stop there, and if we've got any questions, then obviously I'm very happy to take those.